Welcome to this podcast for New Retina Radio. In today's program, Dr. Rishi Singh from the Cleveland Clinic in Ohio, USA, is joined by three global retinal experts to discuss recent updates in our understanding of fluid and neovascular age-related macular degeneration. In this episode, we discuss the implications of the different fluid compartments to disease outcomes in neovascular AMD, and whether management should vary according to where the fluid occurs. We'll be talking about the learnings gained from key clinical trials and considering whether fluid can be protective, which types of fluid need to be treated aggressively, and how AI may play a role in evaluating fluid.
Welcome to this podcast for New Retina Radio entitled Fluid in Neovascular Age-Related Macular Degeneration, an Evolution of Understanding. In this podcast, I'm joined by Drs. Jennifer Arnold, Mark Gillies, and SriniVas Sadda, and we'll be discussing the topic of great interest at the moment, the role and importance of fluid in the management of retinal diseases from the clinician's perspective. I'm Dr. Rishi Singh from the Cole Eye Institute at Cleveland Clinic, and I'm joined by my faculty panel who are going to introduce themselves next.
Yes, hello, Rishi. Thank you for the invitation to join the panel. I'm Jennifer Arnold, medical retinal specialist based in Sydney, Australia, with the Marsden Eye Specialists. I have a particular interest in age-related macular degeneration and involved in many clinical trials, including the fluid study, which has been addressing one of the topics that we are concerned with today.
Now, Dr. Mark Gillies, introduce yourself, please.
Hi, yes, Mark Gillies I'm the Director of Research at the Save Sight Institute of the University of Sydney, and I direct the Fight Retinal Blindness registries.
And Dr. Vas Sadda.
Yeah, thanks very much, Rishi. Yeah, I'm Vas Sadda. I'm a retina specialist at the Doheny Eye Institute and UCLA, and I've been very excited about this topic of fluid, so look forward to our discussion.
So let's start off with just sort of a brief understanding for the lay clinician. Dr. Arnold, maybe you can start off with the compartments of fluid and what our current state is of understanding of both these compartments at this current state.
Yes, when managing neovascular AMD, it's very important to be aware of where fluid can collect within the retinal and subretinal layers. So we really divide the fluid into ones within the retina, which we call intraretinal fluid or sometimes intraretinal cysts. And this can be due to exudative fluid or even degenerative changes. The next compartment is under the retina itself, referred to as subretinal fluid, seen not only in macular degeneration with neovascularization, but also other retinal diseases. And the third compartment is under the pigment epithelium, sub-RPE.
And Dr. Arnold, what have we learned from these compartments so far? What is the correlation from those compartments of fluid and anatomical outcomes and visual outcomes?
Yes, more and more information is being gleaned on this. Some of the early treatment studies, the randomized controlled trials, did show that fluid in different compartments was predictive not only of baseline vision, but of also to outcome vision with anti-VEGF therapy and response to treatment, whereby subretinal fluid and sub-RPE fluid were perhaps a little more benign than intraretinal fluid. So if you have a patient with intraretinal fluid at baseline, they generally correlate it to worse baseline vision. And also the continuation of that fluid or the appearance of new fluid is linked to worse visual outcomes. On the other hand, subretinal fluid is seen in a large number of cases, and it can persist despite fluid and still be consistent with really good outcomes. There's been more and more work on this as we start to better understand and classify the types of neovascularization and their location in the retina into three types, type 1, 2, and 3, which have different patterns of accumulation of fluid.
Dr. Sadda, you did so much work in the Harbor trial with regards to the fluid analyses, and walk us through some of those analyses and outcomes and tell us how that the clinicians who are listening to this tonight learned a lot about the data from Harbor and how it will impact their practices.
Thanks, Rishi. And I just wanted to sort of add on to some of the important concepts that Jennifer raised about these different fluid compartments and the importance of the fluid compartments, whether they were in particular intraretinal or subretinal, that was evaluated in the Harbor study. And in particular, my involvement in this was really a post-hoc analysis specifically focused on this concept of atrophy, which can certainly appear in these neovascular AMD patients over time. And we observed that intraretinal fluid appeared to be associated with more atrophy, whereas patients who had subretinal fluid, either at baseline or at any point during the course of the study, they had a lower risk for development of atrophy, which seems like a positive. One thing I would add, which I think is very important, is some have taken that information to then conclude that subretinal fluid is somehow a good thing. And I would just add that in this study, at least, the patients were getting treated. So it wasn't that the exudation was being left untreated. It was simply that if you had a little bit of fluid, as long as you were under treatment, that did not appear to be associated with any of a negative outcome. And so I think it just really highlights the fact that we have to have a really nuanced approach to interpreting a fluid. And that's really one of the major observations from that trial.
That's a great point, Vas, that it really was a biomarker, not necessarily intended to be seen in that case. That was an important point, I think, of your analysis. Dr. Gillies, you've done so much work for the Fight Retinal Blindness project, and it gives us a lot of insight. What insight have you found from the role of fluid in neovascular AMD from your registry?
Thanks, Rishi. Good question. We've published 3 or 4 papers on this year. Now, the thing about our registry is that the fields all have to be filled out and within range for the data to get into the server. So we have 100% complete data. This is very different from, for example, data mining with the IRIS registry, where you have much more data, many more patients, but the quality of data is very low. So we can look at, we always grade atrophy and fibrosis. We can look at how these things develop. So we looked at the 9-year incidence of atrophy over time. And if we graded eyes that were active versus inactive and put them into quartiles, the eyes that were most active were 4 times less likely to get atrophy than the eyes that were least active. That was published in Retina. And another publication in Retina this year on fibrosis, we found that the eyes that were predominantly active were 1.5 times more likely to get fibrosis than the eyes that were least active. So there's a balance for sure. If you're completely dry, you risk atrophy, but if you're too wet, then you risk the fibrosis. We also published the 10-year outcomes. So in Switzerland, which followed a PRN regimen, they only treated at 60% of visits, and their lesions were active at 70% of visits. In Australia, we had a treat and extend regimen, and our eyes were only active at 40% of visits, and we treated at 80% of visits. So it's a higher treatment rate, less activity, and our eyes got significantly less atrophy, but so the Swiss eyes got significantly less atrophy, but more fibrosis, but they did much worse overall because they got 4 injections a year and we got 5 injections a year. So this is another thing. You've got to be on treatment, but even if you are on treatment, you've still got to give enough. And it looks like you have got to treat fluid and you'll get better results. Now, most recently, we've looked at, we start looking at subretinal fluid only, and we compared eyes in a series of 700 eyes, 12-month outcomes. And eyes that had subretinal fluid only did similarly to eyes that were dry over 12 months, but eyes that had intraretinal fluid did worse, and they gained 5 fewer letters over the 12 months. We haven't looked at the atrophy rates in the subretinal fluid only eyes, but we're expecting to find that's protective against atrophy. So I think in Australia, based on our results from FRB and also from the fluid study, Jenny and Robin's paper, we are tending to accept subretinal fluid and treat intraretinal fluid aggressively. But I think many people will tolerate and not extend, or not shorten with subretinal fluid, and in some cases even extend.
Any comments for Vas?
So yeah, thanks, Rishi. So yeah, I think Mark made some very important points. I guess one concern I would have about in terms of the subretinal fluid, and I know Jennifer will tell us more about the fluid study and the like, is just with regards to over time. And of course, Mark talked about some data that goes on for many years about whether there could be a concern over time. And we certainly know what uncontrolled exudation leads to, because we had decades of experience with that before we had anti-VEGF therapy. So now we're trying to find some kind of tipping point or threshold that potentially could be beneficial. But I would really want to highlight again that it's hard to imagine how fluid itself could be directly protective. I can't think of a really good mechanism. Our hypothesis has been that this is related to the fact that this type of fluid, subretinal fluid, is often associated with the presence of neovascularization under the RPE, something we call type 1 neovascularization. And there's a sort of a thought these days that perhaps there could be some beneficial effect of that neovascularization. I mean, obviously it arose for a reason. And so I would say that, I view the fluid really more as a biomarker for the neovascularization than of this type of neovascularization, rather than a true positive per se. So that's why I sort of feel, we do know that exudation is bad. I think we should be treating it, but then I guess we don't have to necessarily worry if we can't get rid of every last bit of it, despite aggressive therapy.
Well, there's some bits that you do want to get rid of, right? So if there's a lot of SREM or subretinal hyperreflective material, then that looks pretty ugly, and those ones do go fibrotic. So you treat that very aggressively. There's a big difference between that and subretinal fluid. I sort of think of subretinal fluid as maybe it's sort of, it may be sustaining the retina, a completely dry macula. Perhaps that's not getting any blood supply at all. We don't know, what nutrients are getting to the macula. In that case, subretinal fluid may be a source of nutrients, but the retinal structures are still intact. You can see the outer limiting membrane all the way through. Everything looks pretty good.
Yeah, if I may just come in there, I want to stress that point that Vas made there, that these are people under treatment, and overall, our patients are going to be disserved if we undertreat. The question why we first started looking at this issue of subretinal fluid was because our initial goal was to have zero fluid, zero subretinal and intraretinal fluid. And we found that many people were continuing on very intensive therapy for a long time, trying to achieve this end and staying very stable. So it came out to the fact is, can we in fact, under treatment, as Vas points out, tolerate some subretinal fluid? And when we designed our study with that in mind, as accepting subretinal fluid if it were the only sign of lesion activity, then there wasn't a loss. We didn't compromise vision outcomes. But these were people under continuous treatment. And I think as time goes on, it also becomes important to note that really maybe rather than just tolerating subretinal fluid, it's the stability of it. It does tend to fluctuate a bit, but I do think if you have a patient that's extending, getting more and more subretinal fluid, maybe you should intensify a little bit, particularly if it's accompanied by extension of the new vessel under the RPE.
That's a great segue into talking more about your study, Dr. Arnold, and the fluid trial that you conducted. And let's talk about some of the inclusion parameters and some of the outcomes we saw in the study.
Yeah, yes, thanks, Rishi. Yes, this was instigated in Australia with myself and Robin Geimer to ask precisely this question when we observed people that had persistent subretinal fluid with good outcomes as the only sign of activity. So we were asking ourselves, under a continuous treat and extend regimen, which is what how we manage here in Australia, is it possible to be a little more relaxed and accept, or should we aim at zero fluid, including subretinal fluid in our patients? So these were all treatment naive patients included, around 349, and they were randomized to a group that aimed at this zero tolerance of fluid. You treat any fluid in the intra or subretinal compartments, or a group that after a loading dose, if subretinal fluid was the only sign, you could extend out. That, of course, there was one caveat that if there was a very large amount of fluid right under the point of fixation, then you would take that as active, although there were very few eyes that fulfilled this criteria, since subretinal fluid, we know from studies, tends to localize around the perifoveal location rather than right under the foveal center. And what we found was, in fact, we didn't compromise sight. There was no difference in the rate of vision outcomes, but those people were able to have a less intense treatment regimen. They had a 1 injection difference over the 24 months, but a greatly increased number who weren't stuck on 4 weekly. That changed from, I think, around 25% down to around 2% in the people that were tolerant. So instead of having everybody maintained at 4 weeks, we were able to extend. They also had considerably more people that extended out to the maximum interval, which was 12 weeks. So it seemed that by tolerating some subretinal fluid, you weren't compromising outcomes, at least to the 2-year point. So this is how many of us now manage our neovascular AMD patients here in Australia.
So Dr. Arnold, in your analysis of these patients, walk me through how you actually did the presence of fluid, because I think that the measurement is so much as important as the outcome in some of these studies. So was this all reading center related measurement? We're using an AI algorithm to read the fluid. How are you doing the analysis of fluid in this study?
Yes, Rishi, that's a very good point. I think as time goes on, we're going to need a more nuanced measurement of fluid. Initially in the studies, it was just central foveal thickness, which I think is not an adequate point on which to guide treatment. In this study, it was a simple present absent as a qualitative assessment. Now, it was assessed by the investigator, but to maintain masking, the presence or absence of subretinal fluid was read by a masked reading center, which I think was one of the first topics aimed on a PRN or treat and extend approach that actually had the reading center controlling how frequently the injections were on this parameter. So the investigator would say intraretinal fluid present or not, and if that was present, they automatically had treatment and shortened. But the subretinal fluid, they made an assessment, but it was the decision was made on what the reading center assessed.
Now I'm going to talk to you about a study that was at ARVO last year. And this is a study by Ursula Schmidt-Erfurt, who looked at an artificial-based intelligence analysis of the Hawk and Harrier trials. And what she found essentially was sort of counter to what we've discussed this evening, in that the rates of fluid actually were significant in all of the patients studied. And in fact, when you look at those rates and their relationship to the highest quartile fluid and the lowest quartile fluid, all compartments mattered. So maybe Vas, I don't know if you're familiar with the study, or you can comment on sort of these AI-based algorithms. Is this something we've missed as clinicians? Are we not looking at, maybe the central subfield only and not necessarily a volumetric analysis, and that's why we've missed these analyses and the relationship of SRF and this outcome potentially?
Well, I think, Rishi, it is true that a lot of the, pre-AI sort of reading center sort of data tends to focus on the foveal central subfield, because that central area we think would be naturally most important for vision. But one of the things that we've sort of highlighted through this discussion is the importance of just sort of generally understanding if the lesion is active or not. And so, fluid outside of the center also matters, and that may be something that's being reflected in these types of volumetric analyses. Obviously, it's still automated segmentation. There could be other errors as well, but assuming that that's all balanced out, it does seem to highlight that this matters. I think that, as I said, we didn't need these recent studies to know that exudation makes a difference, and so it's not surprising. I think what we're really sort of parsing now is do you have to get every bit out? And I think that's what Jennifer and Mark were talking about, and that's where, again, I personally try to based on the data, try to treat to dry the retina. But then if there is some residual subretinal fluid while under control, under treatment, essentially maintaining control, I think that that's a situation where I'll accept it. I just wanted to also add, Rishi, Mark made a very important point earlier about SREM, which are subretinal hyperreflective material, which is something we haven't talked a lot about so far, but that is something, even in a post-hoc analysis of Hawk and Harrier, was found to be the most important predictor in terms of these different lesion features of vision outcomes. And I think we have to be very intolerant of that. That's very different from subretinal fluid, of course, because this is sort of that more solid sort of component. And I think that that's something that is worth watching very carefully.
That's a really great point, Vas. And if I may come in there, I think it's important to really look at all of your OCT material when you are evaluating these patients, whether or not they need a treatment. You can't just go on one cut through the center of the fixation or one parameter like central foveal thickness on your macular cube map. You really need to assess it. And I agree, looking for subtle features like SREM, which might be the only sign of reactivation before you get intra or subretinal fluid change. And so I would just urge not to, when you're looking for a biomarker on your OCT, that you really need to examine them all. What Ursula's trying to do, I think, is to see if there's an AI refinement of our ability to pick up these biomarkers better than the naked eye in a busy clinic. But still, looking at all your scans is much better than looking at one point. And SREM in particular is important to be detected.
I think Professor Schmidt-Erfurth has got a very interesting method, and she says she can measure this fluid, but we're yet to see what the critical amounts are. Presumably 1 picolitre of fluid is not all that significant, and 100 times that amount might be, but what are the limits? What do you tolerate, what you don't? There's still a lot of work to be done here. At least what we're dealing with, what we can see, you can see subretinal fluid. It's not a difficult thing to see. Intraretinal fluid is sometimes a bit more challenging, but of course you look at every scan. But generally you can pick these things up. There's not a lot of dispute about whether the subretinal fluid's there or not between retinal specialists. And the observations so far, and also the observations from CAT, are pretty much supporting a degree of tolerance of subretinal fluid in my view. And then maybe we can modify and get better outcomes with the AI, but they've got a long way to go, and we need to see what the critical values are. What can we accept and what don't we accept?
Well, that's a great summary, Mark, and I really appreciate all of your participation for tonight's program. Again, the goal of tonight's discussion was really to summarize some of the recent findings from fluid analyses and what we're looking at as clinicians. I think that maybe I can summarize it for all three of us this evening, that certainly these compartments are different. They have different actions. We are not treating necessarily in the ignorance of compartments per se, but we're using these and seeing these as biomarkers of final visual outcomes. And more needs to be done in the field of artificial intelligence, maybe for us to understand better the implications of these fluid compartments and what that might mean. While our initial observations have been really quite good, thanks to many of the work, much of the work that you all have done tonight and continue to do in research, we still need a better understanding of that in the practice in the future. That's all we have time for this discussion. I want to thank our participants, Dr. Arnold, Gillies, and Sadda, for their valuable insights, and I hope you found this discussion useful and interesting. Goodbye.